afternoon, everyone, and welcome to the first aid training / field safety session. This afternoon, our instructor is Mark Bighorse with Cherokee Nation. I'm going to turn it over to Mark. Mark, you have the floor.
Hey, I appreciate it, Karen. Hello, everybody. My name is Mark Bighorse, paramedic here at Cherokee Nation, also training supervisor, instructor, and I do floors and I do the windows, whatever they need to do. We were trying to scramble around. The marshals, they confiscated my room, so the acoustics aren't very good in this room. And I apologize if my voice doesn't carry. They're the guys with the guns, so I didn't put up too much of a fight. I said, I'll try another room. And we'll just go ahead and get started with the steps of CPR, and then we'll cover some first aid topics and open it up for some questions and answering. And we'll go ahead and get started. Well, guys, with CPR, the main focus is compressions now. They want a lot of them. They want your compressions. They want 30 compressions within 15 seconds or 2 per second. So it's pretty quick. So they want about 120 per minute. If you want to use the song Staying Alive, you can. That gives us at the very low end of what we want. That's right at 100 compressions a minute. If you want to kind of speed it up, you can. Unfortunately, the other song that they want to push out there for 120 beats a minute is Baby Shark. And, you guys don't have to sing that when we're doing this thing. So try to I'll just kind of get the cadence for you. First of all, if you walk into the room, this guy's laying in the middle of the floor. He's not supposed to be laying there. So at this point, we're going to try to make sure it's safe for us to enter where the patient's at. There's various reasons why people go down from cardiac arrest. It could be from, just having bad hearts and them having like a heart attack. When you have somebody that's exhibiting signs and symptoms of having a heart attack, what you're looking for is, first of all, they may be kind of clutching their chest, maybe kind of trying to rub that pain out. The pain could radiate down to the left arm. It could localize in the shoulder. The pain could localize in the elbow, so they may just be holding the elbow or shoulder. And it could even localize up to the jaw. Now, if it's in the jaw area, they're having signs and symptoms of having a heart attack, and it's going up to the jaw. That's a bad heart attack. That's in a bad spot. We really need to do something. As far as first aid for this person, what you can do is the best thing you can do is give them aspirin. 324 milligrams of aspirin, which is one regular adult aspirin. But with that, they'll have to chew it up and take a swig of water. And, with aspirin, if you ever tasted an aspirin, it's very bitter. So at that point, they'll need to take a swig of water. The makeup of aspirin is acid, and that's how it kills red blood cells. It kills red blood cells through the acid, and that's how it thins the blood. And what we're trying to do is get the blood thin enough to go around the clot, and hopefully it will. But that's the best thing you guys can do as administering first aid, and have them stop what they're doing. Okay, because if they're walking around and you're trying to get them from point A to point B, that puts oxygen demand on the heart, so it's needing more oxygen, so it's going to hurt a little bit more. So have them stop what they're doing. If you can give them aspirin, and call 911. If you have good cell service, put it on speaker, and they get to your location pretty quick. In the meantime, if it's safe for us to enter where the patient's at, we're going to try to wake them up. Hey, you okay? You all right? If they don't respond to us verbally, at this point, we go by a scale of responsiveness called the ABPU scale, ABPU. A stands for awake alert. And if we walk in the room, this guy's in the middle of the floor, well, he's not. And so he's not awake or alert. So we go down to the next step, is V is verbal. Hey, you okay? You all right? At that point, if they don't respond to verbal, we go to the next step. But if they're only responding to verbal, it could be a medication issue. It could be a medical issue like diabetes or low blood sugar. Again, that's not normal, only responding to verbal. So at that point, go ahead and call 911. The next step is P on the ABPU scale, ABPU. P stands for painful. If anybody's ever grabbed you by the head and just got your knob, at that point, just get your knuckles, bury it down in the chest. What you're trying to do is make it so painful that you get a response. What you're looking for is a grimace on their face. You're listening for a monogram of them trying to push your hand away from the pain. So at that point, if you're only getting a painful response out of this person, again, that's not normal, call 911. But if they're not responding to anything, at that point, the U on our ABPU scales stands for unresponsive. So at that point, go ahead and call 911. We need help there at that point. Now, what you want to do at this level of CPR, I'm not teaching you how to take a pulse, but if you do, this is the time to do it. What you want to do is a head tilt chin lift. Put one hand on top of the forehead, the other one bony part of the chin. And if there's no man like me that have more than one chin, grab a couple chins and tilt the head all the way back. And what we're trying to do with this technique is just getting the tongue off the back of the throat. We're opening up the airway. Hopefully, if there's any brain activity at all, once we open up the airway, they'll start to breathe for us. So we don't look, listen, and feel anymore. And if you know how to take a pulse, great. At this point, do it. You find the Adam's apple, move over to a little groove. But if you're not familiar with how to take a pulse, don't waste time, because what we're trying to do is try to save the person. The person's really not here at the heart. The person's up here in the brain. Their thoughts, memory, personality, everything's up here. So that's what we're trying to save, and we're racing against time. So head tilt chin lift. We're just looking for about 10 seconds to see if they're going to start to breathe for us. And if they're not breathing after 10 seconds, at this point, if they're wearing a button shirt, pop the buttons open. If they're wearing a t-shirt, lift that shirt over their chest. And at this point, we're going to have to do compressions. So it has to be on a firm, flat surface, preferably the ground or the floor. And you're going to be kneeling alongside of them. And whatever arm that you're compressing with, just keep it stiff as possible. Let your upper body do the work, your shoulders right above that person, and we're going to start our compressions. And before we start, if you guys are familiar with the use of Narcan or naloxone, this is a time to use it. We want to get the AED, the automatic external defibrillator, and some Narcan there, if possible. If not, then we'll start our steps of CPR. But if you have this, just go ahead and, again, time to use it. If you're not familiar with Narcan, this is a Narcan kit. Right now, there's it's a 4-year grant through the Oklahoma State Department of Health, and we're on the 4th year of this thing. So if you want to go to any behavioral health center in your city, here it's Cree Oaks, I think Mays County, it's Greene County Behavioral Health, and wherever you go, there should be a behavioral health place. And they're supposed to be the distributors for this stuff, and it's free of charge. You know, all you have to do is go to the receptionist and ask for a Narcan kit. I know within Cherokee Nation, we have our own behavioral health department here, and you can contact Sam Bradshaw or Terry Garrett, and they can hook you up with some Narcan. Very simple to use. Again, it only reacts to an opiate, and we know that when somebody takes too much of an opiate, it kind of slows everything down, especially the breathing. So at this point, we want to get them to breathe again, so that's why we want to use Narcan. The beauty about this drug, if they don't need it, or if you don't know if it's an opiate overdose or not, and you give it to them, you're not going to hurt them. There's no really adverse side effects we got to worry about. The side effects that could happen is they could get a bloody nose, big deal. They could have a fast heart rate, big deal. They could have high blood pressure, big deal. We don't care about that as long as they're breathing, and that's what we're going to try to do with this drug here. It's not like on the ambulance. On the ambulance, we carry Narcan that's an intramuscular IV, intravenous, and with that, we get an IV and we can push it into them. And when I first was able to give Narcan, I actually made a mistake and I gave it all at one time. And when you shoot anything in their vein, it's instantaneous. So at that point, this lady woke up and she was pissed off. She took too much of morphine tablets, and at that point the fight was on, because it wasn't accidental that she took too many pills. She wanted to end her life. And when I gave her the Narcan, she woke up, she realized, well, I'm not in a better place. I'm still in the same place that I was trying to leave. So at that point, the fight was on. In the back of an ambulance, there's no place to fight anybody. So what I do now is I'll just get the IV, I'll just push them up with their Narcan to get them to start to breathe again. And as long as the vital signs are good, I hold what I got, because an unconscious patient is a cooperative patient. And once we start backing up to the ER, I'll slam the rest of it into them. And that way they can find them in the ER. That's a little trick of the trade right there. But with the use of this Narcan, this is intranasal, so it goes up the mucous membranes. It's a slower absorption. So once you squirt it up their nose, we're still going to do our steps of CPR. We're not going to wait and see if it's going to work or not. We're going to continue our steps of CPR. And if it starts to work, hopefully it'll start to wake up for us. But you can give this drug to anybody over 28 days and older. From birth to 28 days is more weight-based, and we really don't have to worry about that. But with this, anybody over 28 days, go ahead and give it to them. The police like it because they can even give it to their dogs. There was a incident about 3 weeks ago in Tulsa where a drug dog sniffed out some powder form of fentanyl and the dog overdosed. The police officer gave the Narcan to his dog, and a couple of days later, the dog was back on duty, fine, doing good. So again, all this does is counteracts an opioid overdose, and the way it works is we got somebody that's not responding to a painful stimuli. We have this Narcan here, and within this Narcan, there should be 2 blister packs of intranasal Narcan. What we want to do is open up one of these blister packs. It comes with an instruction sheet. This is not the time to read it. We have to give this drug, so we'll talk about this in a minute. You'll take the Narcan out, hold it just like so. Very simple to use. Head, tail, chin, lift, because we have to do that anyway. We're going to hold for 10 seconds, see if they start to breathe. In the meantime, we'll just pick a nostril and we'll shove this up their nostril until their bottom of their nose touches our fingertips. And then we just squirt it up their nose. That was 1 dose of Narcan. This is not a biohazard. So at this point, but it is a choking hazard. So at this point, what we're going to do is throw this thing away safely. We can even put it back in the blister pack and put it back in the box if we need to, just throw the whole box away. We put it right there. In the meantime, we still got to do what we need to do. We went ahead and done our head, tail, chin, lift. And at this point, if we have to do our septic CPR, at this point, we'll start our compressions. But this will take about 60 to 90 seconds to work. So at this point, we're still doing what we need to do. And after about 2 to 3 minutes, if the first dose doesn't work and you want to try the second dose, what you do is open it up, head, tail, chin, lift again, and just use the alternate nostril or the other nostril and squirt. And at that point, we'll see what we got. If they don't come back, and it's we'll still do our septic CPR, but the Narcan obviously didn't work. Now that instruction sheet comes within that blister pack. The same information's on the front of this flap. There's a flap with a red strap on it. Just open that up. That same information's right there. So you don't have to open that Narcan up to see how to use it. It's right there. So they made it very simple. And again, if they don't need it, or if you don't know if it's an opioid overdose and you give it to them, you're not going to hurt them one bit. There's really no adverse side effects that you got to worry about. And very safe to use. Okay, so don't be afraid to get one. Keep it on your person or keep it in your home. It's not a drug that we have to really control. It's they want it out there in every household, what they want. But in the meantime, if the Narcan didn't work, we have to do our CPR. At that point, we're going to open up the clothing. If they're wearing a button shirt, pop the buttons open. If they're wearing a t-shirt, lift that shirt over their chest. Get your heel or your hand, whatever one you want to use. You can interlock your hands if you want to. Place one hand on top of the other, grab your wrist, swap hands. Does not matter. At this point, their heart is stopped. You're the heart for them. You're beating for them. And what you're doing is you're getting that blood from point A and the rest of the heart to point B, the brain, through your compressions. We're actually only doing roughly about 25% of what the heart would normally put out. When the heart beats, you got the atrium, you got the ventricles. So at that point, within the atrium, there's a little built-in pacemaker. So it creates that electricity. So the atrium will contract and twist, squeezes blood from the atrium down to the ventricles, and that electrical impulse goes to the ventricles, boom, boom, and it'll contract and twist, and it creates blood pressure right then. Now, when you take a pulse, that's that left ventricle contracting, boom, 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 boom. Since we're doing external compressions, all we're doing with the external compressions, we got your backbone, you got your sternum, and the heart's in between. All we're doing is smashing that heart in between the backbone and the sternum like a big sponge. So roughly, we're only doing 25% of what the heart would normally put out. At this point, it takes about 8 to 12 good compressions to get the blood pressure built up to where we need it, which to the brain. So if you want to breathe for them, you can breathe for them if you want to. It's still an option. I'll show you how to do that. We deem that we have to do compressions. I kneel alongside of them. If I want to, I can interlock my hands. Again, center of the chest, and you'll be fine. Okay, and it goes something like this. We're going down 2 inches deep. We're doing 30 compressions within 15 seconds or 2 per second. So it's like this. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 30th compression. If I'm by myself and I want to breathe for him, I'd hit that chin lift, pinch your nose, my mouth would cover his mouth, and give just enough breath to make that chest move. I'll do that twice. Back to compressions immediately. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. 30 compressions. Again, if I'm breathing for them, 2 quick breaths. If I already in my head said, I'm not going to put my mouth in this guy's mouth, you don't have to. You can do compressions only, hands only CPR, they call it. At that point, if I made up my mind, I'm not doing compressions, what I'm going to be doing, or not doing breathing, what I'm going to do is just take a deep breath and keep on going. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. I'm not breathing for the guy. Take a deep breath, or if I am, just 2 quick breaths. Immediately back to compressions. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. Again, 2 quick breaths, or if I'm not breathing for them, take a deep breath. And this is my 5th cycle. Roughly 2 minutes. 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. After 30 compressions, 2 ventilations if I'm breathing. If not, I'll just take a deep breath. My 5 cycles of 30 compressions, roughly 2 minutes. So think about where you're going to be. Think about how far EMS is from you. And it may take a while. You know, if there's somebody there to help you out at that point, after every 5 cycles, have them take over for you. So they can do for 2 minutes, and then you swap out with them after 2 minutes. Okay? Because you're going to get a little tired, a little winded. It's a little bit of workout. And again, you're using muscle you don't normally use. People can go down from cardiac arrest for any reason. You know, it could be like, if you guys are out in the field, you got done like a beehive or something, and these people are allergic to bee stings. So at that point, you can have allergic reactions to the point where they're not responding anymore. Or you walk in the woods and got a lot of pollen in the air, may trigger an asthma attack. So something could happen where, you know, they're not breathing adequately, so they can go down, and you may be doing CPR, or they just may be their time to have a heart attack. You know, they're walking through there, and all of a sudden they exert a lot of force, maybe walking up a hill or a rough terrain, and all of a sudden, you know, they're clutching their throat or clutching their chest. They go down in front of you. You know, be prepared. It's better to know a little bit about this. If you don't get it textbook perfect, not a big deal. Any CPR is good CPR. Okay? If you want to use a song Staying Alive, you can. If you want to use Baby Shark, you can. So whatever song you want to use. Now the same steps as for a child as the adult. The child's considered 1 through puberty, and the technique's still the same. We're still going down 2 inches deep. We're still doing 30 compressions within 15 seconds or 2 per second. We still want about 120 beats a minute. The only thing different is if you watch this kid go down at that point, they said, well, there's still oxygen left in his blood. They want you to make the call first if you witness this kid going down. If you walk in the room, you didn't know how long this kid's been down, they want you to do your 5 cycles first and then make the phone call if you're by yourself. If you have to, you know, make the phone call yourself. But if they're really tiny, you may just put one hand on the forehead, and it's use the heel of one hand and compress the chest. Okay? Their bones aren't really calcified yet, so their bones give quite a bit. So actually, as far as compressing, it's kind of easy to do it on the kid. It's just the thought about doing it on the kids it messes with your head a little bit. But they need what you're doing. We can break down later. We can cry about it later. But right now, they need what you're doing for them, which is basic life support. Now, the chest is made to go out every time we breathe. Take a deep breath, it expands. It's not made to go in 2 inches. So your first few compressions, you may hear snap, crackle, pop, especially on an adult patient. It's not necessarily rib breakage, but if you do break a rib, that's just a side effect of doing compressions. Don't stop. They need what you're doing. What you're probably doing is loosen that cartilage up. You never have bone-to-bone contact. You have a cartilage in between. And the ribs are no different. They come off your backbone, kind of protect your vital organs, your liver to some extent, but your lungs and your heart. But before they attach to the sternum, there's cartilage around that even. So your first few compressions, you may hear snap, crackle, pop. Again, don't stop. It's going to feel really weird. But what you're doing is getting that blood from point A, the rest of the heart, point B, the brain. And that's the main focus of why we're doing this. We're hoping this comes back, but if it does come back, we want this intact. So the only way to do that is through your compressions, okay? Now, if we have an infant's considered 0 to 1. We don't do a painful stimuli on the infant. What we do with them is simply grab their foot and slap it or flip it pretty hard. What we're doing is the soles of their feet is very sensitive, so really that's their painful stimuli. And hopefully they'll respond to us, start crying or at least jerk a little bit. That just means there's life in their body, and we don't have to do our compressions. We just have to try to keep waking them up and call 911. But on the kids, on the infants, we don't want to do a complete head tilt chin lift all the way like we did the adults. Just because they're a little trachea, the windpipe, it's about the size of a McDonald's straw. And if you kink it off too much, if you tilt it too far back, it's going to kink off like a straw. So we're going to do them more harm than good. So what you want to do is simply tilt the head back where the nose is pointing straight up in the air. And that's hopefully after 10 seconds, they'll start to breathe for us. And if at this point, after 10 seconds, there's no breathing going on, again, we have to see the chest. You have some options now. How are you going to compress the chest? You can use a 3-finger technique. Place your pointing finger right across the nipple line and bring these 2 fingers up. Or you can use the opposite hand with your index finger or pointer finger right across the nipple line and use those 2 fingers, which the first two fingers on either hand, it don't matter. Or you can use the hands encircling technique, which simply your hands are going to circle the chest and your thumbs are going to be about a finger width below the nipple line, and we're going to compress and squeeze at the same time. 1, 2, 3, 4, 5, pretty quick. And if you don't remember anything how to do that, you can always use the heel of your hand and go about 1.5 inches deep on them, or a third of the depth of their chest. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. Just like that. Fortunately, kids are pretty tough. We rarely go out on a kid that's unresponsive. Rarely. That we have before, that's because they had congenital defects. They were born with something going wrong with their heart or something wrong with their body. But most of all, it's due to, we'll say, car accidents, car collisions, vehicle collisions. They're not putting the car seat just right. The car seat may not be buckled in the car. They just kind of had the kid sitting in there, and he's sitting on top of the car seat, and the car seat's not buckled in, and he's not buckled in. So the safety devices work, but you got to use them. They got to be used correctly. So if you have anybody that's needs their car seat checked, I do that all the time here. So they can stop by. Usually I'm here in the office, so they can stop by, ask for Mark, and see if they need a car seat check, and I'll definitely look at the car seats. Not a problem for me. But again, the kids are their bones aren't calcified yet, so they're very pliable, but they actually give quite a bit. Again, an infant's very tough. I remember when my kid was first born, being in the medical field, I was a pipe welder out of high school. I welded pipe and had my pressure vessel cold welding 6G card. I thought I was it. So at that point, I got tired of welding, but heliarc was my main thing, heliarc and stick. And I could walk by someplace and I could look on the weld and I could see whether it's heliarc stick or MIG. And That's because that's my world. I knew what wells looked like. After that, I was a machinist for 13 years. And then I can walk by something that's been machined, and I look at it and I say, hey, that's a nice finish. That's either 32 finish or 64 finish. And I can just tell if it's good machined or not, or it's been ground. I can tell that stuff because that's my world at the time. Now for in the medical field, you know, we learned about the airway, we learned about kids, you know, the main thing is breathing with them. When my kid was first born, I was walking by the crib and I was watching him. I said, man, he's beautiful. Yeah, is he breathing? Put my hands on the crib. I was looking at him. I don't know if he's breathing. So I slapped his foot. He started crying. I hollered for my wife. I said, hey, Mom, he's crying. I think he's hungry. So sometimes we know too much. And at that point, I kind of psyched myself out thinking, is he breathing or not? So I slapped his foot and he started crying. And thank God he did. But just kind of keep your wits about you. Just because if you let stuff get to you, you get too excited, your heart rate goes above 150, it's hard to control, you know, anything at that point. If your heart rate goes above 150 because that shot of adrenaline going through your system, you actually start losing fine motor skills. You can't even open up a simple package. You may not even be able to dial 911 just because of you just start losing your senses at that point. So kind of keep your wits about you, take a deep breath, and keep on doing what you need to do. One thing you may do, and you may have already done it, is if you have somebody that's choking, you may have done a Heimlich maneuver or the abdominal thrust. And it's a simple maneuver. It does save lives. You know, if they're not able to breathe, you know, the brain needs a constant supply of oxygen, constant supply of sugar, and we'll talk about that in the first aid part. But it needs oxygen, so you're not breathing. At that point, this is going to shut down. So you got somebody that's eating dinner tonight, and they get up and they're coughing. Just watch them. At that point, they're moving enough air to cough. We can't do anything about that. Just kind of watch them, kind of keep your eye on them. If it gets to the point where they're coughing and then they making funny noises, they realize they can't breathe. They realize that if I can't breathe, I'm going to die. So at that point, they may have that wild-eyed stare. They may be looking at you like, you know, please do something. At that point, we have to get permission to even touch them. Even though we know what's going on with them, we can't just go ahead and rush to start doing a Heimlich maneuver on them just because they can charge us with assault battery if we don't know this person and they don't give us permission to touch them. So we have to ask, are you choking? Can I help? And hopefully in some way, form, or fashion, they acknowledge they want some help. But if they don't, they wave you off. At that point, legally, you can't do anything. So at that point, if they pass out, because two things will happen, whether they get the object out or they'll pass out for lack of oxygen. If they pass out on you, then it becomes implied consent, meaning, hey, if I wasn't so stubborn, yeah, please help me now. But in the meantime, let's hope that doesn't happen. What we want to do, we got permission from the person to touch them. And don't stand flat-footed behind them because they were in the middle of a good breath. It got interrupted. You may only have about 30 seconds before they pass out on you. So at this point, if you're flat-footed again and they pass out, they become dead weight. It's hard to control dead weight. So what you want to do is put one foot in between their legs, kind of like a boxer stance. You're kind of getting ready for them. And what you want to do is kind of get your landmark, which is use your middle finger, put it right over the belly button. I'm not a very good golfer. There we go. Put your pointer finger right above that and get your opposite hand, make a fist, turn sideways, where it's kind of touching your pointer finger. And if they pass out on us, for one thing, we have them underneath the arms. Secondly, we can kind of set them down on the thigh and we kind of walk them down to the ground. But in the meantime, let's hope that doesn't happen. Again, pointer finger or middle finger right over the belly button, pointer finger right above that, make a fist, turn it sideways. We want to go in and up like a J toward the lungs. It's going to be pretty hard. It's what we're trying to do, whatever air is left in the lungs, we're trying to forcefully pop that out. So it's like a cork in a cork gun. We're trying to force that object out. No set number as long as he's conscious. That's all I can do for him. So at this point, if I don't get the object out, obviously he's going to pass out on me. So I have him here. I take him down to the ground. If I'm by myself, I'll get my cell phone out and I'll punch in 911 and Tell them I got a guy that was choking, now he's passed out. But if there's somebody there, have them call 911 for you and please come back. In the meantime, what you want to do is head, tilt, chin, lift. You just want to look in their mouth. We don't do a blind finger sweep anymore, just like we used to. We don't go in blind. What you want to do is kind of look in their mouth. Now you have an option. Do I breathe for them or not? If you want to breathe for them, what you want to do is simply head, tilt, chin, lift, pinch the nose, try to give a breath. And if that breath doesn't go in because the airway's blocked still, reposition. Try another breath, and if that breath doesn't go in, what we'll do is start our steps of CPR. What I'm trying to do with my breath is I'm trying to force that object, I'm trying to force air around the object, or I'm trying to force it down to one lung. And we don't care which lung it goes into. A lot of times they go on the right side. Just because on the right side, it's more of a straight shot, the path, the least resistance. So they go in there. The left side is more of an acute angle because the heart's right there. It kind of has to circumvent the heart. So then again, we don't care which lung it goes into. We're sacrificing one of them so the other one will inflate. Life over limb at this point. So if it goes down to one lung, great. We'll give them 2 quick breaths, start our steps of CPR, and hopefully they'll come back. They'll start to wake up. But if we're not going to breathe for them, we already made up our mind. I'm not putting my mouth on this guy's mouth. I'll just look. I don't see anything. At that point, I'm starting my steps of CPR. What I'm doing with my compressions, I'm moving the blood around like I'm supposed to, but also I'm smashing the lungs. So hopefully there's enough air left in the lungs when I smash them, it forces the object out after 30 compressions. So 28, 29, 30, I'll look in his mouth. If I see the object, great. At that point, when I see it, that's when I can get it. Okay, rake it out. Continue your steps of CPR until they wake up or until EMS gets there. And I hope everybody's okay with that. I kind of talked fast. I took some coffee just before I stepped in here, so I'm kind of hyped up on the caffeine. Hope everybody's good.
Mark,
Yes.
we had a question about Narcan. What is the shelf life for Narcan, and can I keep it in my field bag forever?
Awesome. Well, these kids have a 2-year shelf life. And but that's for for us, and if we carry them on the animal, we cannot give an expired drug. But home use, you can. We know that the drug's not going to go bad. The last day of this month, when it says July 31st, we know that August 1st, it's not expired technically, and you can actually keep it. And there's been a study where they had Narcan that was 20 years old and still 90% effective. So for home use, you can still use the expired Narcan. As far as keeping it in your field bag, as long as it's kind of climate controlled, it can get hot for a little while, but they don't want you to constantly get it hot. They definitely don't want you to freeze it. Just because that applicator is plastic and it's like a PVC pipe, when it freezes, it could burst that PVC pipe. Same thing with that, it could burst that applicator. So if it's expired a couple of years, it's still good. And you can get it hot for a little while, but not constantly keep getting it hot. Like today, it won't take long for it to get to 120 in your car. And it's okay to get hot like that for a day or so, but it's not going to hurt that drug because there's so little liquid in there. It's very little liquid. It's only like 0.5 mLs. So you can keep it as long as it's like a home use, even though it expired, it'll still be good. And I'll show you guys how much liquid's in there. It's like this, and when I squirt it, hopefully you can see it. Very little liquid. It makes a fine mist. There's 4 milligrams in that, and again, it takes about 60 to 90 seconds for this to start to work. In the meantime, we're still doing what we need to do as far as our CPR. If there's so much of the opiate in their system that overrides Narcan that you just gave, they may go back out again. So get the subsequent dose in the alternate nostril. So one nostril to the second dose, in the other nostril, vice versa. Hopefully that answered your question.
Yes, thank you.
Hey, you're welcome. You're welcome. Any other questions on CPR?
I don't see any just yet.
Cool, cool. You hear me okay? Because the acoustics aren't very good in the room.
I can hear you okay. I've just had to turn my volume up.
Thank you, thank you. Guys, if you have access to a automated external defibrillator, the only time you hook this thing up is when you have to do compressions. And unlike Narcan was 28 days and over, this can be from day one to somebody that's 131 years old. It's made for everybody. So what you want to do is simply grab this. If you have access to one, great. If not, we're going to wish we had one. But the way you want to use this thing is learn where they're located for one thing. If you have one in your facility, you may walk by it every day, and because that box it's sitting in, it's probably nondescript. You kind of walk by it, don't even pay attention to it. But usually there's a white box. There should be an AED sign above it, and just kind of make a mental note that hey, there's an AED there. But in the meantime, if you have to do compressions, you want that machine there as quick as possible. The quicker we can get the defibrillator there and CPR going on, if we get there within 1 minute, we have actually 80% chance of getting something back. Hopefully we can shock them and they'll kind of come back around for us. And very simple to use. They make it where, for one, you have to turn the power on. With this particular model, you lift that lid all the way up. It all comes on when you lift that lid up. Some you have to hit a button to push the power on, and it'll start to talk to you. It knows it's a stressful situation, so it'll start to talk to you. So in the meantime, I have an instructor that messed with this thing, so this is a trainer, so the volume's going to be very low. I may just turn it off. Yeah, too late. But in the meantime, it'll take us step by step how to operate this machine. It's telling me to take the pads, open the pads, get them out. Again, if there's somebody doing CPR, again, I'll just work around them. But if I'm by myself, I grab this AED. This AED actually takes precedent over CPR. It's more important than CPR at this point. And you can see the little diagram on the patches, upper right, lower left. If somebody's doing CPR for me, I'll just work around them. And the patch is just like that, just like the diagram, the heart's in between. So at that point, it'll detect if it's making good patch skin contact. And at that point, it'll say analyzing rhythm and stop CPR. At that point, whoever doing CPR, you stop them, and it's going to see if it's going to shock or not. Some people don't get a shock because they're in a different rhythm and it's not shockable. You don't have to know the rhythms this machine does. There's only one really rhythm it will shock. It's called ventricular fibrillation, VFib. And the only treatment for fibrillation is defibrillation. So at this point, this is the defibrillator. So it reads at shock advised. It's going to say, don't touch patient, shock advised. That button that lit up, when it first opened it up, it'll start to flash for me. What I'll do is just put my finger over that button. I know where that button's at now. I don't know where you're at. So I don't have to look at that machine anymore. I'll say, I'm clear, you're clear, we're all clear, and boom, I'll shock that patient. At that point, hopefully we get something back, but if not, we'll immediately start our steps of CPR again. It's going to count down for us 5 cycles of 30 compressions. It'll probably pause after 30 compressions and say, get breath, and then start counting again. So it kind of gets you back on track. If you kind of get vapor locked and you kind of lose your mind for a little bit, it'll get you back on track with your steps of CPR. It walks you through it. So it's a very user-friendly machine. Again, know where they're located, know how to turn the power on. It's the hardest thing you have to do. Again, with this particular model, lift the lid. Some models you just have to push a button to turn the power on. Then you have a button to push the shock. But sometimes you have to prep the skin. And within the AED, a lot of times there's a ready kit. And within that ready kit, it's a little pouch that's actually sits on the side of the AED. And there'll be a razor, a pair of scissors, some gloves, should be a pocket mask, some antimicrobial wipes, and some paper towels, kind of folded really neatly within that kit. If you can't put your patch on there because there's so much hair, they look like Chewbacca or Austin Powers, what we have to do is just kind of get that razor out, just kind of razor down where the patches go, and then put your patches on there. And at that point, you're ready to go. If you don't have a razor, but you have 2 sets of good pads, what you're going to do is put your first set of pads on there. And if there's so much hair, it's not making good pad to skin contact, this machine will let us know that. So at that point, if it's repeating itself, place pad firmly on patient's bare upper chest. If it keeps repeating that, at that point, just get your pad and rip it off. And what you do is give them a wax job. And again, if that doesn't wake them up, nothing will wake them up. So at that point, you'll have 2 sets of bare spots there, or a set of bare spots. Get your other pad, unhook your old pads, put your new pads in there, get your fresh pads and put them on the bare spots, and you're ready to go. If you have a cancer patient, you have a portacath here, just make sure you don't put that patch over that device, because that device will absorb some electricity. You can move it just an inch or 2 away. We're still good right there. Implanted pacemakers, implanted defibrillators, a lot of times upper left, it's out of our way, it's no big deal. We can still put it upper right, lower left. But sometimes they do replace the pacemaker and they replace them down in here. So if you see a scar, just kind of feel around on the skin. And if you see or feel a protrusion, just move that patch an inch or 2 away, we'll still be fine. Some of the kids are getting piercings. The piercings are underneath the clavicles or the collarbone, and there'll be a stud that's sticking out. There'll be a Teflon rod that goes to the other collarbone. There'll be another stud sticking out. So at that point, if you can't put this pad where you need to, we can always put one pad on the front and one pad directly behind them. And we can still do compressions over that pad, just not gonna hurt the pad one bit. You can use the adult pads on a pediatric patient. So if I only have adult pads and I got a little kid, and I have to do compression on the kid, at that point, you can get your AED and just put one pad on the front and one directly behind them. We can still do our compressions over the pad. It's not gonna hurt the pad. Okay. Very simple to use. If you have a like an old medic, an old paramedic, and you open up his chest, you expose his chest, and you see a DNR tattooed on his chest, that's not a legal document. We still got to do our steps of CPR. And DNRs do not resuscitate, and that should be a piece of paper that is signed and present with them. If it's present, that's their wishes. They don't want anything done to them. So at that point, we stop CPR. But we have to see that piece of paper. The tattoo on their chest is not a legal document. So at that point, we stop what we do, or we got to continue what we do until they produce that piece of paper for us. Again, the use of AED, very simple to use. You can use this in the snow. If you have like deep snow, we can use it in deep snow because the snow has a lot of air in between. It's not like a pool of water. They don't want you to use this machine in the pool of water because electricity and water, water is a great conductor. So we don't want to, we have one patient down, we don't need 2 or 3. So that water will allow that electricity to kind of go out from the body. So, but the snow will not. But it's very simple to use. Okay. Now, with the choking, I kind of rushed that, but if you have somebody that's second, third trimester, obviously pregnant, we don't want to cause any damage to the baby. So at that point, we kind of get underneath their arms, and we just use this, our hand, we turn the side of our fist sideways, and we stand on the center of the chest and straight back. Okay. If we have somebody big and burly, like a big biker dude or just big, they can't get your arms down their chest, can't get your arms around their belly. What you may want to do if there's a like a support beam or pillar in the middle of the room, they're closer to that. Just place their back up against that support pillar or beam, and you're going to stay right in the center of their chest and straight back. If they're closer to the wall, walk them to the wall and straight back. Okay. If yourself are choking, you're home and you're choking, there's nobody around, you can use a high back chair. Again, it's right above the belly button and kind of thrust yourself on that. Hopefully it's kind of like the abdominal thrust and it'll cause that object to come out. a countertop will work. I've even heard of people doing the abdominal thrust on themselves to work. I had a class about 3 weeks ago, and the lady said, I tried the high back chair, it wouldn't work. I tried to do the abdominal thrust on me, it wouldn't work. And I said, how'd it come out? Because obviously you're live and you're here in class. She said, my daughter was taking Taekwondo. And she goes, my daughter's saying, Mom, what can I do? What can I do? She goes, I really didn't know what to do. And all of a sudden she just hit me in the gut, forced that object out, and it did pop out. So she goes, yeah, she hits pretty hard. The object came out, but I'm alive. And now she says, she holds that kind of over me. She goes, Mom, you remember when I saved your life? When they go shopping. And so little girls, they'll do that to you.
Mark, we have another question.
Yes.
How long will an AED stay charged when not used?
Good, great question. I know this particular model, the battery is actually very light. This is a trainer, but the battery is about this size. And this has 2B batteries because it's a trainer, but the actual battery would be just like this, self-contained. And it's good for like 5 years. Depends on where you keep it at, very climate controlled, up to 5 years. And the main thing's probably your patches. The patches are good, usually about 2 to 3 years. And then you'll have to replace the pads. It's the regular model, the patches actually have a plastic divider, and the divider will actually have holes in it. When the patches are together, it's like a continuity tester, so they'll talk to each other. All AEDs do a self-check. They'll do it like every day. They may do it once a week, but they'll self-check themselves, and they'll let you know if there's something going on with them. Usually it's a battery issue or a pad issue. Usually the hardware is very good. And a battery, even though it's saying low, it'll still shock. It's made to deliver so many shocks. Even if you think you got a dead battery, it should work for at least 1 or 2 shocks. But the batteries are very simple to replace with this. You just lift it up, put it in there. If you have any questions on pads, where to buy them, they actually have online stores for everything. So there's an AED superstore that you can go and get anything you need. Pads, batteries, AEDs themselves. And again, as long as you keep them kind of climate controlled, but if you have them in there, I'm on the volunteer fire department also, and we just have them in the truck sometimes. And, it gets pretty warm in the fire station there. So the pads usually, they don't want you to really freeze the pads. If you freeze the pads, they actually degrade pretty quick. So we're replacing pads pretty often. And the pads aren't really all that cheap. They're about, $50 or so per set. So they're trying to keep them in a more climate control, but your AED does have the battery and the pads have shelf lives to them. So the machine will let you know if you're having problems with either or. It's like your kids, when they want to get your attention, they may say, Mom, Mom, Mom. They get a little bit louder each time, more persistent. That's what the beeping will do on this machine. The first it'll be a small beep, a small chirp, and you may not pay attention to it. Pretty soon it's get a little bit louder, more persistent. And so once it wants you to look at it, it wants you to divert your attention to it, to say, hey, there's something wrong with this AED. It'll still work if it's beeping. It's just not made to beep for very long, and it'll stop eventually. The battery actually will go dead if you keep ignoring it. Hopefully that answered your question.
Yes, thank you.
Yeah, you're welcome. They're very simple to use. Again, if you don't know the rhythm, just make sure that anytime you have to do compressions, you want that machine there as quick as possible. Once you hook it up, never take the pads off and don't turn the power off, even if you get something back. Had a medic friend in Muskogee County, EMS, and he actually had a standby at the Wainwright Speedway. The driver went down in front of him. They started compressions. He got the AD there. They shocked him once. The driver stood up and said, what's all this? He said, man, he died. We need to get you to the hospital. He said, I got a race to drive. I'm not going anywhere. He said, no, you died. We got to get you to the hospital. So he finally got enough blood to the brain where he's kind of computing this stuff and he's thinking, well, I don't remember all this happening. So yeah, I probably something did probably go wrong. He got a couple stents. He's good to go. There's really no damage to his heart. So I don't know if he's driving anymore, but at least he's alive to enjoy life without any problems. Any question on choking?
Nope, I don't see any yet.
Okay, awesome. We'll go on to the first aid part of it. But one thing on the choking, guys, when you swallow, your tongue goes back, the little flap of skin right there. I hope you can see it. It's called the epiglottis. It kind of covers up the trachea, diverts the food and liquid down to the stomach where it's supposed to go. And if you ever took a swig of water and it went down the wrong pipe, well, it did go down the wrong pipe. It went down the trachea. And you can't really see it, but down the trachea, you'll see your vocal cords like a little V. And the water touches the vocal cords, they start to spasm. So once they start to spasm, you cough violently, you can't breathe because that's the most narrow part of your airway at the point. So in the day of COVID, you know, when you're taking a swig of water and you're coughing violently, people don't think you had COVID. So I hate when that happens. But it'll subside. You know, they'll start to spasm, then they'll start to relax a little bit. Person, take a breath. While they're spasming, you see the light, you're coughing, never go into the light. It'll subside. So just kind of bide your time. And hopefully it'll work. Can I show you guys one thing? On the ambulances, we have a machine that does our compressions for us. It's called the Lucas device. A little short backboard that fits underneath the shoulders. Like so. Then we have this device here, it clicks in. Click in. Get that pad out of the way. We'll turn the power on. And we'll position this little piston, and then we just turn power on. That's our compression cord. And the good thing about this thing is it's always doing compressions. So before this came about, if we had to move the patient from the floor to the cot, at that point we'd have to stop CPR. With this machine, it's always doing CPR for us. We're proud to say that every ambulance has this on the trucks. So if something happens, we can use this device, and it's a really good device to use. It does have limitations. First of all, they got to fit within the opening here. Secondly, they got to have enough girth to them to actually for this piston to work. If I go too far down, it'll let me know. That's letting this machine know that it doesn't have enough play in that piston to actually do good compressions. So it does have limitations. Hopefully they'll come out with a device that's kind of adjustable, and maybe we can do, you know, we got these little old ladies that are really no bigger than a small kid. This device will not work on them. And we got some people that are pretty hefty, got a lot of girth to them. We get quite a bit in here, but again, it's does have limitations. And the good thing about this machine, if they fit, this thing won't quit. And I always like to say on the OJ trial, when OJ couldn't put the glove on, the lawyer kept saying, well, if the glove don't fit, you must have quit. With this machine, if they can fit, the Lucas will not quit. It'll keep on doing CPR. It's battery operated. So we just put this one battery out, put the new battery in. Each battery lasts about an hour. And if that battery goes dead, there's actually an external there we go. External plug-in. We can actually plug it into our inverter in our ambulance, or take it in the ER. We could plug it into an outlet there. So it's always doing compressions, and it's doing so good compressions that we're actually getting near normal blood pressures out of them. It's smashing the heart that good, and it's just a good piece of equipment. We have a return of circulation, meaning we have somebody in cardiac arrest. We get this machine on them. and the heart starts taking back over, we have a increased return to circulation because of this machine, where we're able to do more, like treat the drugs into them, get them hooked on the vent, and it's a really good piece of equipment. Now for bleeding control, you got some options on bleeding control. I'm not sure what you have on your in your first aid kits, but you may want to get invest in like some tourniquets. This is called a CAT tourniquet, a combat applied tourniquet, and any tourniquet that you use is actually made to go in the extremities. So upper arms, the legs. If you have one of these, just remember high and tight. We will make sure that we put this high as possible. Even though I got a cut here that's bleeding profusely, or maybe an arterial bleed or squirting out every time the heart beats. You put this on, you tighten this up as tight as you can get it around the upper arm, and turn this 3 times, okay? 3 full turns. After 3 turns, it fits in this plastic pouch there. You get that little white thing, put it across. That's a place where it says time. You just write the time. You put this apply this to tourniquet. A tourniquet can be left in place up to 2 hours. Before they would say, well, if we put a tourniquet on, we're going to say goodbye to that extremity. Unfortunately, due to the war effort, they're leaving these tourniquets on, these soldiers that maybe been shot or maybe not an IED explosion. They're bleeding profusely. They get this tourniquet on. They're they're not like today, not in the USA, where the hospital or someplace that they can get to pretty quick. It may take up to 2 hours to get them off the battlefield. So they're finding out we can leave these on 2 hours. There's no deficit to the arm at all or tissue. 2 to 4 hours, you're going to have some nerve damage. Over 4 hours, you have nerve and tissue damage. So up to 2 hours. And the good thing about that is once you put your tourniquet on, they can still use that arm if they still have the lower part of it. And they can, if they have another cut, they can actually hold pressure if they need to. It's going to hurt because you stop the circulation to that extremity, whether it's the legs or the arm. And it's going to start to tingle like you slept on it. When you sleep on your arm and you wake up, it's all tingly, kind of hurting. That's what it's going to feel like. And pretty soon it'll throb. And then sometimes people say that when we put the tourniquets on them, it actually hurts worse than the wound itself. So just make sure you get the tourniquet on. You write the time. If they're kind of unresponsive, you put the tourniquet on. We want to maintain their warmth because the warmth of their body, it takes energy to maintain their own warmth. So we want to try to help them out as much as possible. So if you have one of those space blankets, just kind of put that space blanket around them and maintain their warmth. And because the warmth will promote the clotting factors in their blood, and they'll clot better. But if you got to cover them up, and you covered up the tourniquet, what you want to do is kind of, if you don't have anything to write with, like a Sharpie or something, dip your glove finger in their blood and write TK on the forehead. That lets the doctors know there's a tourniquet there somewhere, and they'll look for it. Okay, so that's a tourniquet. There's a couple different types. That's the combat applied tourniquet. That's about $40 or so. I've seen them anywhere from 40 to $50. This is called a SWAT tourniquet, which is a soft tourniquet. Okay, and the way you want to use this is there's little indicator diagrams here. So there's an oval right there. What they're telling you to do is you want to, every time you make a wrap with this thing, you want to stretch this out where it turns into a circle. Okay, so you just wrap it around the extremity, and each time you turn that to a circle and just keep wrapping until you use all of that, and just kind of tuck it in. And it works pretty good. It just takes a little bit longer to apply than the combat applied tourniquet. But that look like a belt or a strap of some sort. You can improvise a tourniquet out of different things. Don't have to be a commercially made one, but you can use this, a belt or a duffel bag strap or something like that. If you have like roller gauze, you could even use the roller gauze as a tourniquet. Just kind of unroll it a little bit, kind of wrap it around a few times. And at that, my assistant, he went on vacation without me, so I'm by myself at this point. So what you want to do is tie that like a little granny knot, place something in like a stick or a good sturdy pin right in that knot and twist it. And once you get to the point where it stops the bleeding, the two ends, and you'll tie another granny knot, and then it's kind of try to get that little stick or that pin kind of stabilized at that point with your loose ends that you'll have on the roller gauze there. And if you have just a regular cut that you can stop the bleeding with your 4x4s or your gauze, just make sure that the person has gloved hands on. But if I'm able to hold direct pressure myself, just having to hold direct pressure. And once you get it kind of the bleeding controlled, at that point, if you have again, your roller gauze, you always want to start distally away from the heart and work toward the heart. So if it was on my lower arm here, I just start a little wrapping. Like so. And then whatever length that cut is, you just want to make a little twist on top of that cut. You want to put that twist right on top of that cut. That'll keep that pressure directed on that cut. That way it kind of puts a little bit more direct pressure and help control the bleeding. And again, if you ever given blood, what you did is you gave 1 unit of blood, 1 pound of blood, 500 cc's or half a liter. And most of the time you can kind of compensate for that, the body will, and you feel pretty good. You know, you don't feel that bad, but sometimes you get up and, ooh, a little woozy. That's your body trying to compensate. And some days are better than the others. And if I lost some blood and I'm get up and kind of woozy, just have me sit back down, make sure the bleeding's controlled, and kind of have me sit there until the body kind of gets used to how much blood volume I do have at this point. It'll try to compensate, whether through a faster heart rate or something like that. So, or fast breathing rate, it tries to compensate. So if I get to the point where I just can't stand up, definitely call 911. And you guys may be out in the field somewhere where you'll try to walk them back to the vehicle, but they won't walk back for you because they're too woozy. At that point, get service on your cell phone and call 911, or if you have a radio in your truck, holler at dispatch and let them know that you probably need an ambulance out there and they'll come and get them. Again, maintain their warmth, make sure the bleeding is controlled. If you have to use a tourniquet, just make sure that you know at the time you put it on, and if you have to cover them up, write TK on the forehead with something, whether it's their own blood or if you have a Sharpie. That way it lets the doctors know that there's a tourniquet on their person somewhere. Some of you may have access to quick clot or combat gauze. It's impregnated with a hemostatic agent, which this means that it'll stop the bleeding. Most of the quick clots, they come Z-folded. It's like an accordion type of thing. What you want to do is just kind of unwrap it, kind of wrap around your glove finger, and you may have a hole here, and anywhere you can't place a tourniquet. The only place you don't want to really start stuffing this stuff is in any hollow area of the body, which could be the abdominal region or it could be up in the chest. But if it's like where you can't put a tourniquet, upper arm, upper leg, but you got a place where you need to stop the bleeding, what you want to do is start stuffing that and just stuff it in there as tight as you can get it. And as much as you can get it. If you have some left over and you can't place any more in that cut, get your excess, place it right over the top of that wound, Hold for about 3 minutes with about 25 pounds of pressure. And 3 minutes goes by, it stops bleeding at that point. If you have the front of that combat gauze or the quick clot, just kind of put that over over the top of that excess and wrap it up. So when they start to unwrap it, the doctors will know, well, use quick clot, and then they can treat it accordingly. And that's the bleeding part of it. Is there any question on the bleeding?
Nope, I don't see any yet.
Okay, okay. Are you guys familiar with the use of EpiPens? If not, very simple to use. If you have somebody that's allergic to, say, bees, with the honeybee, the honeybee will sting and it'll disembowel itself. The sting will be left in place. And if left in place, that's still, the poison sacs there, so it'll still pulsate up to about 12 minutes, just pulsating the venom into that person. Now, if I'm allergic to bee stings, but just remember, guys, anything that they're allergic to, the quicker the reaction, the worse it's going to be. So if I got stung and an hour later, I just have some localized swelling, that's the worst that I'm going to have it. No big deal. I'll be on my way. But if I got stung and a minute or two later, I'm going, trying to catch my breath. I'm swelling up. My lips are getting bigger. My tongue's getting bigger. I'm getting whelps on me. I'm going to have a bad reaction. That's probably where you're going to have to use the EpiPen. At that point, what you want to do is, if they have it on their person, they may not be able to administer it themselves, and you can help them out. What you want to do is simply grab it, take the safety cap off. Now it's armed and ready to go. You'll have an area where you'll place against your outer thigh. It's made to go through clothing, so you don't have to take any clothing off. And this is on the outside of the thigh. Jab it in there, it'll release. It's like a spring-loaded punch. Hold it for about 10 seconds. After 10 seconds, release it. Be mindful there's a needle sticking out, and just have them rub that injection site, or you do it for them. Try to disperse that epi. And what we're going to have to do next is, with the epi, all it does is it kind of speeds up the metabolism to burn up the histamine that's been released. Now we have to contend with the histamine that's being further released, which is where the diphenhydramine or the Benadryl comes in. If you have liquid Benadryl, you can give them 10 cc's or 50 milligrams of liquid Benadryl. That seems to do the trick. They can drink it, and hopefully that'll stop the histamine from being further released. And all this does is speed up the metabolism, adrenaline, and so it's like the Fast and Furious movies when they hit that NOS button and then the motor goes into overdrive, goes faster. That's all it does. It speeds up everything, and so the heart rate, kind of metabolism, to burn up the histamine that's being released. So, but if you got stung by a honeybee, say that's a stinger and this is my skin, just kind of look which direction this stinger's it's pointing. And what you want to do is kind of get your either credit card, debit card, driver's license. If you have a knife, it's not all that sharp. You just want to kind of flick it out and just kind of scrape it out there. And that'll stop the poison sac from further releasing that poison into them. Again, the quicker the reaction, the worse it's going to be. EpiPen could look like this, or it could look like this. And again, they operate the same. Take that cap off, it's ready to go. I've even seen on TV commercials where an EpiPen looks like a big Tic Tac container. You take that cap off, it starts to talk to you like an AED. And so I'm not sure what the cost is on those things. I know regular EpiPens about $800 still. So still pretty pricey. But that's again, that's an allergic reaction. Just remember, the quicker the reaction, the worse it's going to be. Epi, if you have it, liquid Benadryl at the very least. We go to Florida sometimes in the vacation, and usually we go as a big family. My in-laws and stuff will go. And I had a little niece that went with us, and she was about 15, 16. And we ate at this place called the Indian Pass Raw Bar in by Port St. Joe, down that area. And I went back to the car to change shirts or something. And anyway, I seen her walk out to her car, and I seen her tip up a bottle, and I was thinking, hey, what's she doing? mom and dad's in there, maybe she's taking a swig of something she's not supposed to be taking. So I said, hey, Chelsea, what are you doing? She said, oh, I'm drinking some Benadryl. I said, why are you drinking Benadryl for? She goes, no, we just got there. And she said, I'm allergic to shrimp. I said, okay. Why are you drinking Benadryl? She said, I'm going to eat some shrimp. So what she's doing is pre-medicating herself. And I guess it worked. She never did get to the point where we had to do anything else to her. So it's not really a good thing to do, but she did pre-medicate herself and it did work at the time. And so, people, if there's a will, there's a way. Like, she loves shrimp. Any topics that they want to cover?
No, not anything that I know in particular, and I don't see any other questions yet.
Okay. I know it's getting kind of late, so I'll just open it up for a question and answer. If there's any questions I can answer.
Okay,
There's
I'll
the
check
first aid. Yeah,
I'll check
there's
the
a
chat
first aid.
box.
There's a first aid booklet that you guys can download. I forward that to Karen there. So if you want to ask her for it, and she'll get that to you. And it's pretty handy. It talks about all kinds of things from poison ivy to snake bites to tick bites to spider bites. And I wish we had more time. I wish I was kind of face to face with you guys. Maybe next time. And then we'll cover it.
Mark, I have a
Yes.
question. Is there a topic about snake bites, first aid for snake bites in your booklet?
Yes, there is. Yes, there is. It talks
Okay.
about poisonous snakes and non-poisonous snakes. And within Oklahoma, we normally have the hemotoxin type of snakes, which are pit vipers, which are the water moccasin, the copperhead, and the rattlesnake. They said that the way you can tell the difference is you can look at their pupils, and they have cat-like pupils. But again, if you think about it, how close do you got to get to that snake to look at its eyes? I'm not going to do that. So I'm going to kind of give him a wide berth. For every poisonous snake, there's a non-poisonous snake that wants you to think they're poisonous. They want you to think they're big and bad. They say, well, look at the head. They'll make their head triangular. That's a poisonous snake. There's some non-poisonous snakes that they make their head more triangular just because they want you to think they're poisonous. If you're out in the water and you see a snake in the water, I'm going to leave it alone. I'm going to watch how it swims. If the snake gets in the water and you just see kind of like its head and part of its neck out and it's doing disease, that's a non-poisonous snake because it's not really made for the water. It's made to hunt around the water. Now, water moccasin is made for the water. It can bite you in the water. That's how it hunts. It hunts fish, frogs, mice along the riverbanks or waterways. When it swims, it's more buoyant, so it's doing the S's. Most of its body's out of the water. Okay, so that's a poison snake. That's a water moccasin. They're very aggressive. They kind of like the old men that tell the kids, hey, get off my grass, get off my lawn. They don't want anything they're territorial. They don't want you kind of getting in territory. They stake out a claim on the waterway, and they kind of want to see who's invading their territory. So when they bite, a lot of times when people get been bitten by a water moccasin, a lot of times they have to pry them off of them because they want to make sure they get a good bite in on it. And if you have somebody that's been bitten by a snake, you see 2 puncture marks, more likely that's a poisonous snake. First aid part of that is it's going to be easier said than done, but you want to try to keep them as calm as possible because the more their heart rate goes up there, the more that poison will circulate. So if I've been bitten, I want to keep that in a dependent position, which is lower than the heart. They don't even want you to put a constricting band on them anymore. All they want you to do now is kind of watch to see how much they're going to swell up. So if I've been bitten at 4 o'clock, I'm swelling up to here. I'll make a little mark with an ink pen. 4:15, I'm up to here. 4:30, I'm up to here. That's what they want you to do. And try to get them to the hospital as quick as possible. And do not bring the snake to the ER. There was a little incident a couple of years ago where somebody had been bitten by a copperhead. They had a dead snake in the bag with them, and then when the bag fell off, the snake caused a commotion. It wasn't all the way dead. If you ever seen The Princess Bride, when they said, well, he's mostly dead, he's not all the way dead yet. But the snake was just mostly dead. It wasn't all the way dead yet. So he got off and he caused all kinds of havoc. But poison snakes, usually have a fang mark. You may have one fang because they broke the other fang off. And you'll see some free bleeding out of the puncture wounds because what it does, the venom's actually hemotoxin. It makes the blood very thin within whatever it bites. So if it's a mouse, it bites a mouse, it makes that mouse bleed out inside, makes it more mushy. It's easier for that snake to swallow. With a constrictor type of snake, a non-poison snake, they don't have fangs, they have teeth, and they're very jagged. So when they bite, they have a jagged horseshoe shape to them. The jagged teeth is there to hang on to the prey. Then they wrap around the prey, and then they constrict, and they kind of smash everything. And that makes them, whatever, say it's a mouse, makes it more mushy, makes it easier for the snake to swallow. So venomous snakes, just give them a wide berth. There's really, you got to get down pretty close to actually tell the difference. So just kind of give them a wide berth. They say that pit vipers have the heat-seeking pits right behind the nose, but then again, you got to get pretty close to the nose to look at it, and you're probably within striking range. So just kind of give them a wide berth. Any other questions, Karen?
No, but I do have a comment. They say, thank you so much for this presentation. Very helpful and informative. So I don't see any other questions in the chat box just yet, but if you guys don't get a chance to put it in the chat box and you think of a question a little later, you can just send it to me and I'll forward it on to Mark. And like Mark said, I have the handout that I can email anybody that would like a copy of it. Just let me know. It looks like a really good informative booklet. So I don't see any other chats in the box. So with that, thank you so much, Mark. We appreciate it very much. Very good information. And we'll end this session for today. And everyone, be sure and join us Tuesday on August the 3rd at 8:30 for the Natural Resources session. So with that, everyone, have a good afternoon. And thank you again, Mark. We appreciate it.
Thank you. Thank you all. Thank you.
Bye-bye.
Bye.